Yeah, I'm a little vertically challenged. Yeah, thank you. Good morning, everyone. My name is Belisario Arango. Thanks for having me. Thanks for the invitation. And just to dovetail on the topic that was just discussed, I'm a hematologist oncologist, and I actually saw yesterday a male on his mid-30s who actually presented to the hospital with abdominal pain. Long story short, had splenic and renal infarct, hemoglobin above 20, hematocrit of 66, and presumably from testosterone use. So today we will discuss precision oncology, some of the advances in the cancer care setting. This is a very exciting topic. It's an exciting time to be a cancer specialist. These are my disclosures. We will talk mostly on lung cancer, breast cancer, and melanoma. And the biggest advances in the treatment of cancer in the past 10, 15 years have been really on the understanding at a molecular level that has allowed us to develop targeted agents, and also in the front of immune therapy. So lung cancer, these are the statistics. It's about 230,000 patients a year. It's responsible for more deaths than the other 5 most common cancers combined. And keep in mind that without treatment, stage 4 lung cancer has a median survival of about 3-4 months. Remember that number. I'll present some other slides that will be impressive. These are the different histologies of small cancer, of lung cancer. Small cell lung cancer has been on the decrease as the smoking pattern of patients has decreased. The most frequent one is adenocarcinomas. These are molecular subsets of lung cancer, and it's a bit of an alphabet soup, but the point of this slide is that we're discovering more and more molecular alterations in these cancers, and about half of the patients who are diagnosed with lung cancer now are able to fit into one of these categories in which we could use a targeted agent up front and not have to necessarily use chemotherapy. These are some of the pathways that we see in lung cancer and other cancers. If you see the slide here, this is the wall, the cell wall, cytoplasm, extracellular component, the nucleus. And this slide is trying to demonstrate how monoclonal antibodies act, or where they act. The monoclonal antibodies are, as you know, large molecules. They do not cross the cell membrane, and they interact in receptors outside of the cell membrane, different than small molecule tyrosine kinase inhibitors, which are able to cross the membrane and interact in the intracellular component pathways of cell growth. So these are some agents, some examples. We have many of them. We target the epithelial growth factor receptor, the anaplastic lymphoma kinase ROS1 receptor, BRAF, amongst others. This is a study that was presented, a phase 3 study on patients with lung cancer who harbored the epithelial growth factor receptor mutation. They all had stage 4 treatment naive. They were randomized to receive this first generation tyrosine kinase inhibitor, erlotinib, versus standard of care chemotherapy. And if you see, there's a significant improvement in the progression-free survival, exactly doubling the progression-free survival, favoring a tyrosine kinase inhibitor in this population. Patients on the chemotherapy arm had a progression-free survival of 5.5 months versus 11 months on the tyrosine kinase inhibitors. To expand in this discovery and add to it. This is a second-generation tyrosine kinase inhibitor, Osimertinib. This was approved initially in November of 2015 for patients who had an EGFR mutation, lung cancer, stage 4, who developed resistance to a first-generation tyrosine kinase inhibitor. And cancer is like any cell. It's trying to survive, and it will find different ways to do this. And these patients were having mutations at the site where the tyrosine kinase inhibitor would bind to this EGFR, and it's called T790M. So it was approved in that first setting in 2015. This is in the treatment-naive, this study. It's a phase 3 study. All of the patients had stage 4 lung cancer, treatment-naive, EGFR mutated, and they were randomized to receive this second-generation tyrosine kinase inhibitor, Osimertinib, versus a standard of care EGFR tyrosine kinase inhibitor. And there's a substantial benefit of progression-free survival in patients favoring the newer tyrosine kinase inhibitor, independent of if they had or not CNS metastasis. And this is something important because remember that these are small molecules and they are able to cross the blood-brain barrier, and these second-generation tyrosine kinase inhibitors are able to do that more efficiently. By the time of this publication in 2018, they had not reached a median overall survival benefit in these patients. This is the same study, just when the median overall survival had matured enough. And let me show you the numbers. So with this newer agent, we have patients who have stage 4 lung cancer who have a median overall survival of 38 months. I'd like to pause here because I think this is just remarkable, and let us absorb these numbers. We have a patient who has stage 4 lung cancer who's taking a pill, and they have a median life expectancy of 3 years and some months. It's quite amazing. Melanoma, let's switch to melanoma. Melanoma is the most common, Utah has the highest incidence of melanoma in the country. I think it's because we have many sunny days, we have a higher altitude, and we have a more prevalent Caucasian population. There's about 100,000 cases in the United States every year, and melanomas are predictably unpredictable. I have a patient in the clinic that had a melanoma resected in 2002, and he's doing great, and now in 2021, so 19 years later, he's found to have a relapse, and there's not many cancers that do that. We know melanomas are highly immunogenic, and approximately 50% of them harbor these BRAF mutations. And it is important because we have targeting agents that focus on exploiting that BRAF mutation on patients. So again, this cartoon depicts the cell membrane, this intracellular domain. BRAF pathway is part of the NRAS BRAF MEK pathway. And these are the small molecule tyrosine kinase inhibitors that target the BRAF pathway in the intracellular domain. The first one that was approved, first generation, Belisario, was studied against dacarbazine in all patients who had stage 4 melanoma. This is a phase 3 trial. They were all BRAF mutated positive and treatment naive. Randomized 1-to-1 to Belisario versus standard chemotherapy. And you could see here from the Kaplan-Meier curves, significant improvement in progression-free survival with a hazard ratio, highly statistical significant of 0.26. To build up on that, now we combine a BRAF tyrosine kinase inhibitor with a MEK inhibitor, which there's many, but just to show you a study, this is dabrafenib plus trametinib versus standard of care single agent BRAF inhibitor, bemurafenib. All of these patients had stage 4 melanoma, treatment naive, BRAF mutation positive, randomized one-to-one into these two different arms. Again, substantial improvement in progression-free survival favoring the combination of dabrafenib with trametinib. So this is a proof of concept. If we see this slide here, now we're not only blocking BRAF, but we're also targeting, so dabrafenib blocks BRAF and trametinib blocks MEK. So it's a dual blockade of the pathway of growth for these cancer cells. This is more mature data. It's really impressive. Patients at, all the patients at 2 years, there's over 50% of them who are alive. At 5 years, about a third. And patients who had less tumor burden, low LDH, and less than 3 sites of metastasis, look at this. 5 years, over 50% of them are alive. Again, these are oral agents, non-chemotherapy. Let's move to breast cancer. October's Breast Cancer Awareness Month. As you know, it's the most common cancer in the United States. Stage 4 is considered to be incurable, and about 25% of breast cancer patients express HER2. We've had multiple HER2 targeting monoclonal antibodies since the 1990s. The first one that came out was trastuzumab. It's a monoclonal antibody that targets the extracellular domain of HER2. Now we have pertuzumab, and we have some intracellular small molecule agents. This data was presented in ASCO. I remember very well. I was in the plenary session when they presented this. This is an antibody-drug conjugate. It's a very interesting drug. It's regular, old-fashioned trastuzumab. This is the molecule of trastuzumab, but it has a highly, highly toxic chemotherapy agent called emtansine. This is a chemotherapy agent that we were having difficulties to use because it's so toxic that the therapeutic index was very, very narrow. So patients were not able to tolerate it. So what the beauty of this compound is that they were able to bind this highly toxic chemotherapy agent to the molecule of trastuzumab, and it would target the HER2 receptor. It would be phagocytosed inside the cells. Lysosomes would degrade that linker, and then this emtansine would be released intracellularly and targeted only for HER2 positive cells, and that's the mechanism of action. And when I spoke with the scientists that were developing this, they would say that the most difficult part was to find a linker that was stable and not allow this molecule to be released when it was in the circulation, and only when it's phagocytosed intracellularly. So I like to see this agent sort of like a Trojan horse. You know the story of the Iliad, that a Trojan horse was brought into the city, and then all the soldiers got out. And anyways. So this is the study that led to that approval of that agent. The Emilia Study. All patients were HER2 positive, stage 4 disease. They had received at least 2 lines of HER2 targeting agents. They were randomized to TDM1 versus, at that time, a second-line standard of care was lapatinib, which is a small molecule targeting agent. and capecitabine, which is an oral form of 5-FU. And there was a substantial improvement in the progression-free survival, about 50% almost, favoring TDM1. And again, this is the median overall survival. These are patients that have been treated. Remember, these are 2 lines of treatment or more. And now we could tell patients that on average, it's about 30 months median overall survival with TDM1. So immune therapy, this is very exciting. This has revolutionized the care of many cancers over the course of the past 5 years. And the whole concept is, we know that patients who are immune suppressed, patients who have HIV/AIDS, who have a condition that suppresses their immune system, or patients who are receiving immunosuppressive drugs, for example, those patients who have had a lung transplant or solid organ transplant, kidney, liver, heart, and we suppress their immune system, or patients who have an autoimmune condition in which we give them immunosuppressants, we know that all of them are at a higher risk of having cancers, and we know that the immune system plays an important role in fighting cancer in general. So immune therapy is intended at harnessing the body's own innate immune response to target and eliminate cancer cells. This cartoon is very, very basic, but to give you an idea, the T cell, when it engages with the T cell receptor, the major histocompatibility complex antigen in the tumor cell, it leads to activation of the T cell. But the tumor cells have this PD ligand, program death ligand, that binds to the PD-1 receptor in the T cell and inhibits this T cell activation. So we have molecules, monoclonal antibodies, that are able to bind either the PD-1 receptor and or the PDL ligand receptor and prevent that inhibition of the T cell, and that leads to an upregulation in the immune response, and that's how these cells are able to go after the cancer. Checkmate 017. This is a study in lung cancer. Patients had received at least 1 line of treatment. They were all stage 4 squamous cell carcinoma, and they were randomized 1-to-1 to receive standard of care docetaxel chemotherapy versus nivolumab. And here we see a significant improvement in progression-free survival and median overall survival, favoring nivolumab over standard docetaxel, and about 42, almost twice as many, 42%, almost twice as many patients were alive at 1 year. To build on that, this is a different immune therapy agent, pembrolizumab. Keynote 189 studied the combination of chemotherapy alone versus chemotherapy and immune therapy. I remember when they launched this study, I was skeptical about it. I thought, the immune therapy is going to, the chemotherapy is going to suppress the immune response in these patients, and if anything, it's actually going to blunt that effective response, and it's probably not going to work, but it did. These were all stage 4 cancer patients, treatment naive, all with lung adenocarcinoma. They were randomized 1-to-1 to receive pembrolizumab plus carboplatin pemetrexed versus carboplatin pemetrexed standard of care. And here we could see a significant improvement in the median overall, in the progression-free survival, favoring the combination of immune therapy with chemotherapy. And significant improvement in the overall survival, also favoring combination immune therapy with chemotherapy. This is a study that I'm showing here, not because it has tremendous improvement in survival or progression-free survival, but because this was for the first time in over 30 years, a new drug was discovered and approved for the use of patients with small cell lung cancer. Stage 4, patients were randomized to standard carboplatin etoposide plus atezolizumab, which is an immune therapy, versus carboplatin etoposide plus placebo. And there's an improvement in overall survival. For the first time, we were crossing the 1-year overall survival on patients with stage 4 small cell lung cancer. So immune therapy in melanoma, we have, in addition to the PD-1, PD-L1 receptor in melanoma, we have the CTLA-4 receptor, which stands for cytokine T-cell ligand antigen 4. So this CTLA receptor is part of the CD28 B7 receptor complex, and when it binds to the B7 receptor in the cancer cell, it leads to T-cell inhibition. So we have a monoclonal antibody, ipilimumab, that blocks this TCLA receptor. It binds to it and prevents that ligand with the B7 complex, and it leads to T-cell potentiation. This illustrates the two different pathways, the CTLA-4 pathway activation, T-cell receptor, major histocompatibility complex, CD28 and B7 binding in the T-cell, and in the periphery, the PD-PD-L1 binding and the anti-PD-L1 and anti-PD-1 receptor monoclonal antibodies that inhibit that binding. So we combine ipilimumab, a CTLA receptor, plus nivolumab, a PD-1 receptor monoclonal antibody, versus ipilimumab alone in patients with treatment-naive stage 4 melanoma. Randomized 2-to-1, and significant improvement in the median progression-free survival favoring the combination. The waterfall plot, you could see the majority of the patients derive benefit from this treatment. And more importantly, and we're trying to be cautious using this word in oncology, there is potentially a small subgroup of patients that we're saying they might be cured, this 8% of patients at 5 years in the combination. And at 5 years, over 50% of patients with a combination of ipilimumab, nivolumab for stage 4 melanoma are alive. This is remarkable, again. 5 years, more than half of the patients are alive with a combination of immune therapy without the need of chemotherapy. This is a slide that I like to present. This is almost 30 years ago. You recognize Magic Johnson. This was his press conference when he announced that he had been diagnosed with HIV. And in 1991, the diagnosis of HIV was a death sentence. And here's a picture of him in 2019, healthy, carrying on a productive life. And the reason I present this picture is because I'm cautiously optimistic and hopeful that perhaps in our lifetime we're able to replicate what we have done in HIV/AIDS in cancer patients, in that we're able to perhaps target multiple different pathways in their circuit of cell growth with either small molecules and or monoclonal antibodies. And perhaps, like HIV/AIDS, we're not able to cure the cancer yet, but patients could carry on a healthy, productive life for many years with their cancers. That's my presentation. Thank you. Questions?
Where are we at with prostate cancer and targeted immunotherapy?
Yes. So thanks for asking that. The question is targeting immune therapy for prostate cancer patients. The biggest discovery for prostate cancer patients is targeting BRCA. We know that BRCA is mutated in many prostate cancer patients, and we have PARP inhibitors that target these small molecules, and they have done a remarkable job. That's one area of improvement. We have a immune therapy called Sipuleucel T, which pretty much we are able to obtain the serum of the patient, send it to the company that produces Sipuleucel T, and they reverse engineer the T cells to recognize the prostate cancer cells, and they send that back to us, and we can actually infuse that to patients. And the latest, greatest for prostate cancer is PSMA diagnostic testing and Lutathera, pretty much. Yeah. Any other questions? Yes.
Any concerns about inducing autoimmune disease with immunotherapy?
Yes. Thanks for asking that. That's something that is very important. We are upregulating the immune system, and that is the majority of the side effects that happen and occur with these patients. So these patients have symptoms and side effects similar to a patient who has an autoimmune condition, and that's a problem. They can have severe pneumonitis, hepatitis, they can have colitis similar to a patient that has Crohn's disease or ulcerative colitis, rash. So that occurs in about 20% of patients, and we need to monitor for that. And when that occurs, we need to, depending on the severity, treat them with steroids to suppress their immune response. So that's one thing. It's something we monitor. And the other component is that patients who already have an autoimmune disorder, it's contraindicated to give them immune therapy. I have a lady who has a urothelial cell carcinoma, and she has multiple comorbidities. She has lupus, and she was not able to tolerate systemic chemotherapy, and we're limited in what we can do with her because she's not a candidate to receive immune therapy based on her underlying autoimmune condition.
I have a question for you regarding that illustration with the programmed death ligand. Are you noticing anything, because that's a normal process that our body goes to make sure that we clear out all the riffraff in our cells. But I'm wondering if you're seeing any issues with other cancers developing while you give that drug.
Yes. Good question. In theory, this should actually decrease the incidence of other cancers because our immune system would be even more enhanced and would target any other cancer cells. But yes, it is true that there are some other cancers that form with immune therapy, particularly skin cancers. That can happen, yeah. Thanks.
One more question. On this side. How do you manage some of these amazing improvements in the public safety realm? For example, I've seen a commercial driver, come in with brain mets from lung cancer, and then 3 months later bring in an MRI scan report where he's completely clear. Do you let that guy drive the school bus?
Yes. I don't know. I would be qualified to answer that. I would probably have to send that patient to a neurologist and have a deep assessment and determine if he's able to go back to his normal function, sort of the same way we do with a patient who has epilepsy or seizures. But if the patient has not had any problems with their neurologic function, they normally would be able to go back to their baseline.
And what's the prognosis? I mean, what's the likelihood that they're going to have trouble in a year or 5 years? And is it going to be a seizure be the first symptom? I mean, those are the kind of questions that we wonder.
Yeah, it's hard to predict that. It's hard to predict where are these patients going to progress. We need to monitor them very closely. But these treatments, the majority of them are not curing patients, with the small exception perhaps of that subgroup of patients with immune therapy in melanoma. Let's see what time shows. But these patients will progress, and fortunately that's not the only treatment option that we have. So we have other second and third generation small molecules that can be used, and we can also go back to chemotherapy. But it's a good problem to have. Okay.
Yes. I have a patient that is under 40. She had colon cancer. Surgery was done, and they feel they've accomplished what they started. They're pretty free. But we cannot stop her from smoking, and she just will not quit. And so what is a repeat of colon cancer or lung cancer? Is that more apt to happen or not?
So what is the repeat, like the incidence of the patient developing colon cancer?
Yes, she's under 40 and had colon cancer surgery, and they feel they have it, but she continues smoking, and I wondered what the incidence of repeat colon or possibly early lung cancer with a patient like this.
Yeah, so actually there's some data that perhaps smoking might actually decrease the incidence of colon cancer. And so I wouldn't encourage anyone to smoke to decrease their incidence of colon cancer. But yes, there's obviously an increase of lung cancer, pancreas cancer, renal cell carcinomas, head and neck, bladder cancers, etc. Not to mention all the other problems with smoking. What we do for those patients is after the age of 55, it's approved to do CT, low-dose CT scans of the chest on a yearly basis for screening of lung cancer. Yeah. Okay, thank you.